got a couple more coming. You know, we scheduled this, and I think we kind of forgot about the debate.
Oh, yeah.
Yeah, just tell her so.
Alexa, stop. There we go. But we'll have some fun anyway.
Okay.
There's another lady walking in. Will you grab me a water?
I will. In fact, here, you can just have one. Just have a seat wherever you're comfortable.
Okay, thank you.
Absolutely.
Normally we do have a lot bigger crowd, but I think a lot of folks stayed home for the debate.
Yeah, I'm tape recording it, so I'm watching.
I didn't even think about that until this morning, and I was like, oh yeah.
Well, they play so many reruns of everything anyway, you always see the highlights anyway.
Right,
so
right.
Whether you watch it or not, you figure it out.
So we've got a couple more folks gonna come up here, but I'm gonna go ahead and get started. Welcome to the knee pain workshop. We're gonna cover a whole lot of stuff. Hopefully it's not too boring. At the end, I hope you get a little idea about what you might can do to help with the knee. Well, as we go through this, if you have questions, feel free, just ask me. Very, very relaxed on how we do this. One of the first things I always ask is, who's dealing with knee pain? And the folks in the back are raising their hand too. I've dealt with a little bit over the past 30 days, not terribly bad, more just stiff than I would say pain. But whenever we talk about knee pain, one of the things we want to keep an eye on is what were we doing when the pain popped up? Was it walking? Was it getting up and down out of a chair? Was it just sitting still, sitting for an extended period of time, riding in a vehicle? There's a lot of potential things that can cause that knee pain. And usually it centers around whenever we put a lot of weight on it and then start to bend. Those are the ones we want to keep an eye on. Occasionally it can be simply because of just when we're doing nothing at all. And that can represent a whole different type of problem. So what were you doing when you had that knee pain, and how bad was it? Medical people use the 0 to 10 pain scale. 0 is no pain, 10 is your worst imaginable. Mine, at its worst, maybe a 2. I doubt it ever got higher than that. We'll talk about it in a minute, knock on wood or metal. I haven't dealt with a whole lot of knee pain, and I'm perfectly happy about that. So how did I come? My name is Luke Haynes. How did I come to specialize in knee pain treatment? First off, we opened up our office out here in Mineral Wells on March 9th of this year. Great time to branch out and expand. Been in Weatherford opened the office up there in 2001. We'll talk about my education. I graduated PT school in '94, so I've been doing this for a couple of years. But as far as the knee itself, my first experience was an injury in high school football. It wasn't terribly bad, but it was keeping me up at nights, and it was an issue. I didn't know anything about a physical therapist. I'd never heard of such a thing at that point. But the trainer took me to see one. They looked at my knees, evaluated. Honestly, nothing terribly bad. Gave me some exercises to do and some flexibility to work on. And I haven't had a problem, again, knock on wood, since. So part of why I know what I know is dealing with mine and keeping mine in decent shape. My education, I graduated from Texas Tech in '94 with my bachelor's degree. Went on, taken all sorts of advanced education and training over the years to learn to be better and do more things. They decided to start giving physical therapists a doctorate degree. And so mine was actually the last year that they handed it out as a bachelor's degree. So I didn't want the young 22-year-olds coming out and having their doctorate and me getting showed up. So I went back in 2012, I finished mine through MGH out of Boston. Some of my achievements, we'll talk about this a little bit. One of the tools relatively new in the United States that we use as clinicians to deal with pain is what we call dry needling. Well, I've been certified in 3 different organizations, one of which is one that I created. So, because it's a good tool, I broke it down, I restructured what dry needling is, and we'll go over it. And I had it trademarked through the U.S. Patent and Trademark Office, and then I teach it to clinicians across the state, across the country. There's some that I even do some online across the world. So I'm the senior instructor and the author there, and I do some collegiate lecturing from time to time. My clinical experience, I've treated or supervised over 500,000 patients for patient treatments in my going into 27th year. Dry needling, over 50,000 patients with over 250,000 needles in that approach. So, let's talk a little bit about the knee. We'll go over some anatomy and what all the pieces are and what they do. The bones themselves, the first one is the thigh bone or the femur. And there's a worksheet in there. You don't have to fill it out. It's just there for you to follow along and give me something to work through. On this, you don't have to remember the fancy words or anything. But the femur or the thigh bone is the upper bone in the leg. Out here at the side, we feel the little knob that they get right here. And then up at the very top is the ball that goes in the socket for the actual hip joint. The shin bone or the tibia is the one down on the bottom. If you walk by something, you hit it right there, that's the tibia, or your shin bone that you're hitting there. Those are the 2 main bones that comprise the knee joint. Now there's 2 other bones that come involved as well, and can play a role in the knee. The one is the outer bone or the fibula, which is just that little bone. It's the outer chicken bone out at the side out there. Just a little bit of thing. If you have a break in the lower leg, odds are the fibula is going to be involved. Very often that one does break. The interesting thing, we can have a break down there, and a lot of times they don't have to fix it. It doesn't bear weight, so it's not incredibly critical, but there are some things that come and attach to it that reproduce some of the pain that we have in the knee. So we get a little bit interested in what's happening with that one. And then finally, the kneecap or the patella. And it just sets, come back. It actually serves as, and we'll talk about the muscles in a second, as a pivot point between the muscles of the upper thigh and where they attach right here. So it's just kind of a fulcrum, providing a little bit more motion there. A lot of times this one, we'll talk about it, whenever you feel grinding in the knee, it's the back of that kneecap it's got some cartilage back there, and it gets ground down a good bit. And that's where we see a lot of that popping. And you kick that knee out, it grinds, it's that thing right there. And so the joint itself, every joint in the body has a particular description on what type of a joint it is. The hip joint, the shoulder joint is what we call a ball and socket. It's just a ball in a socket. Here at the knee, it's just a hinge joint. It says it's a synovial joint. That's a fancy way of saying there's a lining around that joint that holds all of the grease, if you will, the synovial fluid inside the knee. And that grease is what lubricates these 2 surfaces. But the knee itself is just, it's a hinge joint. And so we've got the lower surface on the shin bone, where the upper leg comes down with its 2 outcroppings here, and they ride on those surfaces. And the upper part on the upper leg bone is just a horseshoe shaped structure there that sits in there. So when we look at how this thing moves, let's see if it's going. So as you can tell, there's a lot of potential friction building up in this space right there. So as a hinge joint, it's moving a lot from the front all the way to the back. And we'll talk about the cartilages in a minute, but there's the cartilage that we think of, which is the circle shape, which we'll get to. And then there's a different type of cartilage that lines those areas that roll. So there's a lot of cartilage, there's a lot of protection for the knee itself. So the muscles on the front side, on the thigh, there are 4 of them there. I'm not gonna challenge and try to make you memorize all of those things. Specifically, the quadriceps, they're called, the rectus femoris, the vastus intermedius, vastus lateralis, vastus intermedius. You don't have to remember those. Y'all should know them. You shouldn't know them.
Thank you.
And so 4 muscles on the front of the leg. On the back of the leg are hamstrings. Do I have a second picture? Yes. So they all attach, the hamstrings, so the muscles on the front of the leg all attach right here. And on the back of the leg, they attach right on our sit bone, our butt bone right here. And so sometimes we can get pain up there. It's a different presentation altogether. But they do come down and attach on the side and on either side of the knee. And a lot of times, more common in men, if we have tightness back here, we're gonna feel it either on the outside or on the inside, more commonly on the inside. So they play a role in it as well. So those are the basic muscles that make up what's happening at the knee. There are muscles of the calves that come up as well. There's tons of them down there. They do cross a little bit. It's rare for them to be involved with knee problems. They're more often involved with foot problems. So we don't discuss those. The tendons and the ligaments. There are tons of tendons and ligaments in the knee. We're gonna hit the basics. The meniscus, there's one on either side. On the outside, so the one on the inside, and the meniscus is just the cartilage, is a lot broader, a lot bigger there on the inside because we carry more weight on the inside. Here on the outside, it's a little bit smaller, and together they form the main part of the cushion of the knee whenever it's bending and moving. The ligaments, 4 main ligaments. Let's talk about the 2 in the middle first. It's called the ACL and the PCL. So if you're an athlete, there are at least 2 ACL repairs in here that I know of right now. There may be more. But an athlete, this is the one that tends to get injured. And the problem with that one is the knee starts moving this way. We lose a lot of stability and a lot of control with the knee. So those are very important. One on the back side, one on the front side. The other 2 on the inside and the outside. The one on the inside is actually pretty big. It's attached. It actually attaches to the meniscus or the cartilage. If there's an injury, say we injure the ACL, some of the ligaments in the middle, odds are we're going to probably injure that ligament as well. Interestingly, the one on the outside, although it's a lot smaller, is a lot stronger. I don't know. I didn't build it. And then we have 2 more tendons. So we talked about the muscles of the upper leg, and they come down and attach to the kneecap here, and that was called the quad tendon. And then below it is what we call the patellar tendon or the patellar ligament below. And so a person that has some weakness in the leg, or say they've injured it or they've had some surgery and they can't quite get it straight, well, they're going to stand with the knees bent a little bit, or with advanced arthritis, we'll see this too. And so these muscles are always firing. Tend to get a lot of tenderness right above the kneecap, right below the kneecap. And there are things that we can do about that. Oh, there's the last one. So that word says pes bursa. That is a short version of a word that says there's a little cushion right here. And then when the knee starts to wear down a little bit, it gets extremely tender. So if you will, you're sitting there. We'll do this as a group. So I'm going to take on my inside leg here. I'm going to find right the bend between my knee, or between my thigh and my calf, and I'm going to push in right there. Odds are it's going to be tender if you push down there, and that bursa sits right there. A lot of times, this is our main complaint of pain, is this right here on the inside. And so a lot of times we try to target that to reduce that down. All right. So in the worksheet, we have the answers to the questions. What is the knee? The knee is a hinge joint. What movement can it do? It can bend and flex, and it actually, at the very end, it actually rotates just a little bit. The large muscle groups, the quadriceps on the front and the hamstrings on the back. And then the knee consists of 4 bones, the thigh bone, the shin bone, the small outer bone, the kneecap, or you can call it the femur, tibia, fibula, and patella. So talking a little bit about traditional physical therapy. Again, I've been at this a while. When I first came out of school, I thought I was the sharpest person, smartest thing out there, and I knew everything, and I knew the textbook stuff. And when we start dealing with the knee, and this applies to the shoulder, any other unit that we use, 50% of the people that we worked with, and I'm going to say worked past tense, 50%, they got a little stronger, they did some exercise, they felt a little bit better, but they really were still dealing with that same problem. It didn't really correct any of the pain, any of the inflammation, any of the underlying loss of movement. And so, you know, sure, they did what they did. Relatively unsatisfactory. There were 25% of people that, man, we were able to do things and get things moving and going, and there was a great story, and therapy was a success, and didn't have to have surgery or anything like that. And then there's a full other 25% that all therapy did was make it worse. Do a little exercise, pain gets worse, and nothing is any better. You do it a few times and you stop and end up either putting up with it or going to have surgery. As we'll look at later, we changed a little bit. I say we. How I approach the knee and how I approach dealing with pain and limitation of function, I stopped just looking at the knee. I started looking at what is the ankle doing, what's the hip doing, what is the back doing. All of those things play critical roles in what this thing does. I started looking at the knee as a machine instead of these different little parts. It's built within certain tolerances, and it's got to do certain things. And if it doesn't do those, then that pain elevates. I mean, honestly, you're here because knee pain. You may have lost some function, but it's the pain that's the number one thing. Get rid of the pain, then we can worry about the function. And so I changed how I looked at that, and I applied these other 4 areas. Now all of a sudden, 90% of the people we see with knee pain, we can take care of. We can knock that pain down. We can get them moving back to where they want to be. There is still 1, maybe 2 out of 10. Nothing we can do about it. Going to need to have surgery. Some things are just so far gone that something has to be done. But these are the ones I'm going to talk about. 90, 85, 90. I may have stretched that just a little bit. Not much. So what we look for is can we reproduce that pain? So this right here where I had you push down here, that's not your knee. Your knee is above that and inside there. That is muscle and other tissue that comes down there. So what we want to know is, can we reproduce that pain? Most of the time, yes, we can find a way to reproduce it in the tissues around the knee. And if we can, the good news is it's reproducible, and we should be able to make it reducible. Again, back to the worksheet. If your knee pain is reproducible, then it's reducible. So let's talk about pain. And I'll use me for an example. In the past 30 days, the worst pain I've had was, again, maybe 1 or 2 out of 10 at most. My knees have been good. And then I have pain for me, it's really when I'm not active. If I'm just sitting, the knees start to ache a little bit, I pop them, and that's really when I don't really have any of these other things. But for some people, it's when they're walking, going up and down stairs, getting up and down out of a chair, standing for long periods of times. Now this doesn't bother my knees, but it works a number on my back. But for some people, that's for the knees. Kneeling down, squatting, bending, running and jogging. And so again, if there's a cause, if we can reproduce that, then there's a reason it's happening. We can elicit a change, and there should be hope for that. So a quick story here about what to do with the problem, and this revolves around any problem. It can be about a bad relationship. It can be about your knees. It can be about our political system, since we're having a debate. So what can we do about it? We can ignore it. So the example I use is the potholes in the road. When we lived, and we recently moved from west side of Weatherford to halfway between there and here. When we lived over there, we lived on an area where there was a pretty sharp incline to go off of our street back towards town. Always had potholes there. City would never fill them in. It just got worse and worse. So what did they do about it? They ignored it. So, and that's what we do with knee pain. It'll go through cycles of up and down. It's a little better, it's a little worse, but we ignore it, hoping that it'll get better. Was it Einstein? Forget who said it. The definition of insanity is the same thing and expecting a different outcome. So yeah, we ignore it and hope that it'll get better. Mountains and valleys, but it's probably not going to change much unless we. Step 2, we can alter it. So what is that? We can fill that pothole with asphalt. So right before we moved, they did come in. This area had about 6 potholes. It had one really big one, and then 4 or 5 little ones around it. Came in and filled the little one in. I mean, the little one's in, but they didn't fill the big one in. I don't know why. I'm not in charge of the roads over there. So within about a week, we had a big rain. Cars went through, and then the asphalt was all out, and then we had the exact same problem again. So we altered it, but it really didn't fix any problem. So with the knee, what does that represent? Well, here we're looking at drugs, injections, or surgery. Now, there are times where we have to have surgery. There are times where injection is okay. There are times when drugs can be helpful. But altering it by doing these things is usually not a good long-term solution. And the reason why is this. Let's take drugs and injections first. Drugs and injections are going to reduce, and we're going to talk about this, going to reduce the pain and inflammation short term. What it's not going to do is change the long-term mechanics of what's causing this pain and inflammation in the first place. If I have a body ache, do I take Advil? Do I take medication? Absolutely. But it's not a solution for long-term problems. And if we don't change the mechanical piece, then we still have the issue. If it's a surgery issue, and then the big thing is my knee is worn out, that's bone on bone, doctor tells me I've got to have surgery. And you very well may. The problem is, if you're having those issues and you're dealing with an intense amount of pain, you probably aren't, that knee probably isn't moving mechanically like it needs to. And even if you have surgery, whether it's a complete knee replacement or if it's just a scope to clean things out, you still have to do the work to get it moving right. Surgery itself doesn't fix that part. That's the nasty little secret on the other side. And sometimes it's worth it to get it moving right first, because then maybe we can skip all the pain associated with it there. So we can alter doing those things. So finally, what do we do about it? Well, we handle it. In the case of the potholes, well, the only way to really do that is to repave the road. Get the road functioning like it's supposed to. Got an arch in the middle of it so the rain comes off, and it's structurally sound. With the knee, what does that mean? Either getting natural treatment or learning to manage your symptoms. So with the symptoms, what are the symptoms? They're pain, obviously, and then mechanically or functionally getting the knee to move right. Fortunately, the knee does, we said 3 things, it really does 2 things we're concerned with. It straightens and it bends. And more importantly, it has got to straighten. If we can't get it straight, then we have problems. So, worksheet number 1, single biggest mistake knee pain sufferers make is we ignore it. We've got other things to do, hope it'll go away. And those are the 3 things you can do about it. You can ignore it, you can alter it, or you can handle it. Well, you've taken the time, you're having to record the debate, you've got the emails, you've come in to listen to me talk. So we know something's going on. You've taken one step towards handling it. So there are tons of causes of knee pain. I've lumped a lot of stuff into 4 categories here. But let's talk about imaging because that's the elephant in the room. So on the left is x-rays of a normal knee joint, and with x-rays what we're looking for is the amount of space. So here's the upper leg bone or the femur, and here's the shin bone or the tibia down below. And in between you can see this little valley and mountain. And the black space, that's the cartilage. We want to see a nice amount of space in between there. That means the cartilage hasn't worn down significantly, and things should be looking pretty good. So we see that on both of these here. On the one over here, we start to see that space has gotten quite a bit smaller. It's not quite as bad over here, but there's a little degeneration here. This one's pretty close. There's some bone on bone action going right here. And so this is normal. The problem with this picture is you would expect that this person would have tons of knee pain and that this person would be perfectly fine. Not so. This person can come in and be at an 8 out of 10 with knee pain. And this person can come in and really have no problems at all. Matter of fact, I see knees that are much worse than this, that I'm not even seeing them for their knee problem, I'm seeing them for something else. So we have to be careful when we're talking about imaging that we're actually diagnosing and treating the pain instead of trying to fix the pictures that we're taking. So I won't spend much time on this, but MRI studies of adults aged 50 to 90 show that on average 35% of that age group have meniscal tears. In men, that number climbs to as high as 56%. So there's a lot of meniscal tears out there. However, 61% of them didn't report any knee problems. So we know we can have meniscal tears. We know we can have damage in there, but not have problems. This machine is designed to have some wear and tear. And the issue is not are we having wear and tear, but are we having pain and limitation with it? So 61%, over half are having these things but aren't having any problems with it. So the translation, don't panic if you get an x-ray, if you get an MRI and it shows that there's some wear and tear. It's not the end of the story. It doesn't necessarily tell us anything about the pain. So it brings me to the vomit and the barf. So what is vomit? Vomit is being a victim of modern imaging technology and the brainless application of radiological findings. So it's treatment based on imaging findings alone without any clinical correlation. I know a lot of docs that rely super duper heavy on their imaging. And by the time they get to us, a patient gets to us, yes, that imaging is there, but the problem isn't really associated with that. It's somewhere else. So, got to be careful. So back to it. 4 main causes of knee pain. One is a ligament sprain or tear. So there are 3 different types of sprains. One is something that you can't see, doesn't show up on any imaging. It's just a little pull. You roll your ankle a little bit, it tweaks it, it gets some blood in there. There may be some micro tears, something like that, but we don't see it there as far as actually any tearing. The second grade is there's actually some tearing that's taking place. So if the tendon is here or the ligament is here, there's actually a small tear. And the third is a grade 3, which is a complete rupture. Grade 3 is a problem. Grade 3, we're probably going to have surgery for that one. Grade 1 and grade 2, not so much. Those things can heal. So a little picture that kind of shows this. It goes really fast. So we're going to look right up here. We're going to have a grade 1 sprain, little force, nothing visible. Grade 2, we can now see some tearing. And then the grade 3 thing is completely gone. This grade 3, all of a sudden, this knee is unstable. And so there's no support on the outside or the inside, or if it's the ones in the middle, to keep it from moving back and forth. Those things are going to force the meniscus, the cartilage, to really wear out super fast, and it's going to buckle and you're going to have real problems. So the grade 3 sprain, nothing we can really do about that. We can try a time or two, but that'd be it. The second piece is a meniscus or cartilage. damage. So we talked a little bit about what that cartilage, the meniscus, looks like. It's just these two rings of tissue in between the tibia and the femur, and it provides the cushion for that knee to slide. And so here's a little picture or a little video that talks about, this is a bucket handle tear. And so there's the meniscus. And so it's with time and wear, you can see that it pulls back, and now we've got a tear there. I wonder what all this picture does. So the problem with a meniscal tear like that is there's not really any blood supply in the meniscus. There's a little bit on the outside, but there's really not much at all. So that really can't heal. Now, it can get shoved back over, and it can still function well. They still do a few of these every now and then, or back in the past, they used to go in and try to sew that together, but there's so much force that we put through these things that they really can't keep those pieces together. To do it right, you had to keep your weight off of it for about 6 months, which is hard to do. And then still the outcomes weren't all that great. So anymore what they do, if there's a lot of pain going on, they'll go in and take their little, I call it a Dremel, they'll take their little clean out tool, they'll just cut that and trim that away and get it out. And so at that point you just have less cartilage. It's smooth and it's good, but it's just, you have less of it. And then we have arthritis. So here we'll talk about, we talked a little bit about, so here's the upper thigh bone, the femur, and we talked about where the femur and the tibia roll on each other, that we have this area that's got cartilage. Well, you can tell that it's eroded quite a bit. There's a lot of wear and tear in there. This is a different type of cartilage than is the meniscus down here. So here we do see that eroding cartilage here. In some cases we can have some exposed bone. Right here would be where the kneecap would sit. So again, that's going to start wearing out on the back side of the kneecap. It goes on long enough, you start to see some bone spurs. Those are problems because on the outside we do have the muscles that are coming down and trying to attach right there. And the meniscus can start to erode as well. So a lot of things start to wear over time. Now here's the interesting thing. We have all of this stuff going on, but the problem is we don't really have any nerves in our cartilage. We don't have any nerve endings that sense pain here. So this isn't, although this looks horrible, we don't really get pain from this because there's no nerves there to tell us that it hurts. What we get pain from are the structures around this. The lining of the joint itself can get irritated in the event that we have, say, rheumatoid, something like that. But it's usually the muscles around. This changes how we use the knee, and so our pain is more often this little place that we poked on down here. It can be above, it can be below, but most of the time, these structures here aren't the problem, as bad as they look. Now that being said, that's going to create some grinding and crunching. But we can have some grinding and crunching as long as it's not painful. And then finally, problems away from the knee. And this is really important. So yes, we have this knee problem, but as you see, we have a nice straight line from the hip all the way down to the foot. Believe it or not, the low back has a lot to do with the function of the knee. So one of the most common things that I treat and deal with is, let's call it sciatica, for lack of a better term. This pain on the side of the hip coming on down. Well, it travels all the way down. It can attach to the outside of the knee here, and it can come across to the inside. And so just a direct connection of the muscles themselves from back here can create that. The nerves that supply all of this area also come from L2, L3, L4. So all of this low back stuff can radiate pain down here as well. Even beyond that, when we talk about the hip and the foot and the ankle. So let's say you have flat feet. So if we have flat feet, what tends to happen is that foot rolls in right there. Well, all of a sudden we've changed the dynamics of how the knee functions. Now all of a sudden we're putting a lot more weight on the inside, and that's going to wear a lot faster and give us a lot more pain. Well, with that, I guess we can use orthotics and different things. But even if we have knee pain, we're going to change how we walk. So knee pain person is going to more set that foot down than let it strike. So that small change can affect things, even though it's happening at the back, the hip, and the ankle. It's going to change where all the load tends to take place, which is at the knee. So looking at all these other areas, probably half the knee problems that I deal with are not at the knee. They're either above or below that I deal with, that I see with patients. So, top 4 common causes of knee pain. Number 1, the ligament sprain or the tear. Number 2 is the meniscus or the cartilage damage, degeneration or tearing. Number 3 is arthritis. And then 4 is problem in the foot, ankle, hip, and or the lower back. So briefly, I want to talk about the 3 phases of healing. So I talked about the nerves, or the lack of nerves in the cartilage in the meniscus. What we want to really focus on is dealing with pain and inflammation. Again, more often than not, that pain is outside the knee joint. It's in the muscles, it's in the ligaments coming down to either side. Sometimes it's in above and below. The majority of times it is that inside business. If it's on the outside, odds are it's something else. So we want to deal with that pain and inflammation. If we can deal with the pain and inflammation, we can target, number 1, the piece that'll let us get what we really need to do, which is prevent loss of motion. Again, if we can get the knee straight, all of a sudden we can function a lot better. Most people with significant knee degeneration and pain are going to stand with a little bit wider base, and the knees are going to stay bent. Why? Because it's a little bit more comfortable on the knees that way. But it makes the pain more prevalent. So number 1, we want to knock out pain and inflammation. Number 2, once we get that pain down to a tolerable level, then we really want to focus in on getting that normal motion and strength back. Now, you don't have to look like this and do all of those things, but you do have to get normal mechanics of this machine back to where it should be. And then finally, the phase 3 stuff is maximizing your motion and strength, getting back to life, preventing re-injury, and preventing future pain. So one of the things that's very, very misleading, a lot of people think, and even say you have surgery, is that once you have dealt with a knee problem, shoulder problem, neck problem, back problem, whatever the problem is, and let's say you've reached, well, I'm not even going to say that. I used to say once you've reached about 50 years of age, which I have. But dealing with a chronic problem, you have to work on it for the rest of your life. There's no getting around it. There's some strengthening, some flexibility work. It doesn't have to take an hour a day. Most of the time you can do it inside 5-10 minutes at most. I have a series of about 6 exercises that I'm supposed to do every day for my back. I try to remember to do them every day, but maybe if I'm lucky, I do them 3 times a week. Right now, it's sustaining me doing them 3 times a week, and it takes all of about 5 minutes, and I do it before I get out of bed. If I don't do them, it's the difference between walking around in a lot of pain or going to work and doing whatever I need to. And the same principle applies to the knee. There's a functional limitation to that knee that if we can restore that movement and at the same time bring pain down, we're good to go. Things are looking good. But we've got to identify those things and move on with it. And so what does successful natural treatment look like? Well, number 1, it's rare for somebody to come actually see us for intervention and us not put our hands on that body part. If it's a knee, if it's a shoulder, if it's a back, if it's a neck, if it's a hip, we need to change the mechanics of what's happening in there. Something mechanically is not moving right. And I'm not necessarily talking about a hard, like a chiropractic manipulation, although we do those. but changing the mechanics of how the thing works is incredibly important. A lot of people that go to, that have therapeutic or whatever type of intervention, one of the problems and the reasons there's not good success is they're not trained in putting the hands on and moving that body structure around. That's critical. The second piece, extremely important, and this is the most important part for maintaining long-term control here, is the strengthening exercises and stretching. Almost always there's a flexibility limitation that's changing the mechanics of how this knee is working. And so once we identify that, then we can have you work on those pieces, and that way you can maintain it with good strengthening. Again, once we have this machine working correctly, 9 times out of 10, regardless of the amount of degeneration in the knee, then we're going to be in a good spot to keep it there. The challenge is getting that pain down so that we can get to that point. And then finally, and this has to do with dealing with the pain. And so I mentioned dry needling. I use dry needling almost exclusively for dealing with pain. What is dry needling? It's a form of acupuncture, I guess we'll say. I don't use the traditional Chinese approach to qi or meridians or yin and yang or any of that sort of stuff. But we know our physiology, we know exactly where all the parts attach and what they do, and we can use that to force the body to create a healing immune response to that place where we apply that treatment. And that can really knock things down considerably. I've been able to significantly reduce my back pain, neck pain, shoulder pain. My knees are good. With this, I have less pain today than I did 20 years ago because of that. Another thing we do, because we do have some people that are very scared of needles and so forth, men especially. We have a high-powered Class 4 laser. Actually, we don't have one here. It's in our Weatherford office. But this can also be used, both of those things, to break that pain cycle. So I like to classify things according to their pain level, because the pain level limits what we can do as far as our movement. So if our pain sits at, say, a 5 out of 10 or above, man, we need to do some of this stuff to get that pain under control. If it's a 2 or a 3, you know, that's not terrible. We need to start getting things moving and figuring out the mechanics of what's going on. But we have to get that pain under control first. So, here's what to do next. People who might, so before I do that, one of the most important things, I like to give people a couple things they can work on. Probably the most important thing, one of two things. Again, I mentioned the most important part as far as the knee functioning correctly is being able to let it get completely straight. Now, you don't have to be able to sit completely tall, because a lot of men, especially with tight hamstrings, women with tight hamstrings, can't sit upright and their leg out straight. But the most important part here is that knee needs to be able to go all the way down. It doesn't need to be here, it needs to be there. So as you're at home and dealing with, you're watching the debate, tighten this upper thigh muscle and gently push it down for a few seconds. If there's one thing more important than anything for the health of the knee, and I know it's super basic, but that's this movement right here. Sitting in the recliner, you have to be cautious because it leans right there, so it looks like you're really pushing down. And pushing it there is better than nothing. But if you can get in a kitchen chair and get that leg up there and push it down, it doesn't have to be tons. Maybe you do it 10 times. That's a really good way there. The second one is, and I'm going to pretend like I'm laying down in bed, because I'm not going to get on the floor. But let's say I'm laying down in bed, and I'm going to bring this knee up to here. I'm just going to hold right behind, and this is to deal more with the muscles on the backside. So we want to get these strong, we want to get these limber. So here what I'm going to do, I'm just going to reach up, and I'm going to, again, tighten that muscle, and I'm going to get a nice stretch back here. I'm going to hold it about 5 seconds, and I'm going to let it off. And I'm going to do it again. and I'm gonna let it off. And I'm gonna do it about 3 to 5 times, and I'm just gonna hold it 3 to 5 seconds. Really nothing more than that. I challenge you, work on for the next week. Do that once in the morning. If you remember, do it again at night. Both that straightening it out and stretching it that way. A lot of times that can really reduce pain by 2 or 3 points easy. And 2 or 3 points can be huge in bringing pain down. So what to do next? So if your pain is a 2 or 3 out of 10, you've been dealing with this for a while. It's nothing critical, but at some point we may want to get together. You may want to do it now. We may want to do, you've listened to me chat. I will gladly, for people that come in and see me for this, I'll gladly do a free screen. Take a look at the knee, see what's going on with it, see if we can give you some more things to work on. If your pain is sitting at a 5 or 10 or more, that's too high. We can exist with pain at that level, but we can't live. If it's that, let's set up to have you come in. Let's do a full eval. Let's figure things out. Let's get you some relief. There's some numbers there if you want to. The rest of our group here is going to be available for my offer. So again, you came and listened to me gibber about all this stuff. So I'm offering this free consultation, a free screen. Here we're going to look at certain movements. I'm going to feel your knee to poke on it, see what's going on, find where that pain is coming from. And then we're going to look and see if there's something that can be done to heal it. It may be something as simple as giving you some more exercises to work on. It may be something more significant. Maybe pain is elevated. We need to do some of the other stuff. I'll give you some tips on that. At the end, if you decide you want my help, so be it. If not, I'm not going to try to sell you on it. Whole goal is just to give you some information on my opinion on what's happening with the knee and what you can do about it. So consultation, evaluation. A consultation, honestly, it's about the time. I'm just going to take 15 or 20 minutes. I don't let people just come in off the street and I look at them for free. I have to do that to family, and I don't mind. But people that come in here, we're going to do this free consultation. We'll determine a potential cause. We'll talk about what successful treatment looks like. I'll give you some things to work on, kind of like these 2 things right here. If it's a physical therapy evaluation, we're going to get a lot of your information. If there is any imaging, I ran the imaging down a little bit, but if you've got some, I want to look at it. We'll identify the cause of what's going on. We'll go ahead and apply some successful treatment to the pain that's going on. That can take up to 45 to 60 minutes. And then we'll put together a plan of care to treat what's happening. I have no idea how many slots I have. So if this is something that if you want me to look at it, feel free. If you want to set up to come in and just really get after it. Again, for me, it's about what is that pain level like? Is it fairly low and minimal? Then we can do this whenever. You can just take the information that I've given. If pain is elevated, let's take care of it. So, any questions? I see one coming.
Well, if I wanted to do some physical therapy, say, and my pain level is not at a 5 out of 10, but about a 1.
Okay.
And I suppose I decided I want to do some physical therapy, and I'm a Medicare person. Do I have to have a doctor referral to apply for Medicare to pay for physical therapy?
On Medicare, yes.
Uh-huh.
How often do you visit with your doctor?
Once every 6 months.
Okay. Is your doctor aware of any knee issues?
Oh, yeah.
Okay. Most, and I'm not going to ask you who your doctor is. Most of the times, I will have a person come in if they haven't seen their doctor in a little bit, and there are times we'll do an evaluation and just send it over to the doc, and they'll sign off on it, and they'll say perfect, and that's good enough. Depending on who it is, sometimes we'll send them something, or even have you call them, and a lot of times they'll just fax something over to us, and that's good enough.
Okay.
So that's an easy one. I've never had To date, I've never had a physician balk at a person wanting to be proactive to take care of the problem. What we do as far as physical therapy is all, because it's physical therapy, there's regular Medicare secondary stuff applies.
Right.
So,
Okay, thank you.
you're welcome.
Well, I had knee replacement on this knee.
Okay,
This knee is starting to do the same thing, and I don't want surgery again.
okay,
And I'm at about a 5 or 6 on this pain, and I feel like it's the same thing here. So when I saw the workshop, I thought, well, let's see what you can do for me.
how long ago was the left one?
2 years ago.
Do you mind kicking it out straight for me?
This one,
Mm-hmm. Okay, what about the other one? Okay, yours, I can sit here and I can make some stuff up. Easiest thing for me is to evaluate that knee. Because there are times, absolutely, very frequently you get one done, and if the other one hasn't had to take too much of a load for too long, then it will decrease that load and you can get it back in good shape. I can tell you, I'll shoot straight with you. If it's just, hey, this is just too far gone, then we can look at that. But it looks like it's straightening out pretty well, and if we can identify the cause of pain, I'm less worried about what's inside the knee than I am about everything that attaches around it. Because if we can bring that pain down, you're fairly young. You're a little bit young for knee replacements, quite honestly.
I'm 61.
Yeah,
So
kind of young for them. At a minimum, if it can be pushed back at least 10 years, that would be great. But that would be my recommendation. At a minimum, let's take a screen, let's check it out,
okay,
and let's see what's happening.
okay, that sounds great.
So, all right, thank y'all for coming out.
Thank you.
Hope you get back in time for the debate, and hope it goes the way that you want.
Doesn't start for
I
an
doubt it
hour.
will.
They got plenty of
Oh,
time.
it's still another hour to go.
Doesn't start till 8.
I kinda doubt that it will be any fun at all.
Yeah, I don't.
That first one was like, oh my God, we didn't just quit.
Yeah.
It's,
Turn off the dang mics. It's terrible.
well, they're supposed to on this one. We'll see.
Well, let's just put on the boxing gloves and get it over with.
See a couple of 70-year-olds up there just.
I know it. So I'm a teacher here in town, and so I would like to do a free consult with you, but can I do one, like, 4:15, 4:30 in the afternoon, one afternoon? Whenever you have time.
And honestly, they know my schedule.
They'll set me up,
They're-
yeah.
I talk and I do great with this as far as the real stuff.
Yeah.
They
I
know all the
understand.
smart people stuff.
I'll go talk to them. I'd like to go ahead and get an appointment for a consultation. Okay, my deal is, I was told several years ago, eventually you're gonna have to have knee replacement. But I don't really think I wanna do that, at least, I'm 72 next week or two. And I don't really wanna do that until I really have to.
Right.
And I don't think I'm there yet. And I just soon avoid it, because to tell you the truth, one of my daughter-in-law's aunts had knee replacement a year ago in the summer, and she died a week later.
Oh, goodness.
Oh my gosh, we don't wanna go there. So,
I tell you what, knee
Anyway.
replacement is probably the worst pain I've had.
It's,
I've always heard that hip replacement's a lot easier on you than knee replacement.
sign me up for
Yeah.
6 hip replacements before I do a knee replacement.
Because the knee is just so much more complicated than the hip, I
I
think.
had no idea it was gonna be.
Yeah, my mom had knee replacement, she had one done and she never would, you're brave to have the second one done, cause she never would go get the second one done. And so it crippled her eventually, cause she wouldn't get it done.
It's,
Well, and the thing is, it's been 2 years and I still have pain. So it's like, okay, if I have pain here, what's the point of that? If I'm
Right.
gonna have pain here, if I can manage this pain, why don't I just manage this and not have to worry
and
about
see,
it?
that's my thing. Having the knee replacement, having any surgery is not a guarantee that the pain goes away.
Right.
It's a guarantee that they can make the picture look
Yes.
pretty again, but it doesn't guarantee
Right.
that this. I've had lots of surgeons as patients. They don't want surgery either.
Mm-mm.
Yeah,
They want to avoid it if they can.
sure.
Now,
I think
and
so
they're good
too.
friends of mine. they want you to have surgery because, I mean, that's their
That's
job.
what they do.
Well, thank y'all for coming out.
I appreciate it.